Dear colleagues, my name is Gyula Szőcs. I would like to share my 9 months progress report with you. My topic is investigating the safety and efficacy of surgical and conservative knee cartilage preserving techniques. About myself, I work at the Uzsoki Hospital at the Department of Orthopedics and Traumatology. My supervisor is György Hangodi, and my SMS is Váncsa Szilárd. Our vision is to decrease the number of total knee arthroplasties in Hungary, and we would like to achieve that by increasing the use of knee cartilage preserving practices. We have 2 ongoing projects right now. Our first project started September of last year. It's comparing the safety and efficacy of meniscal repair and meniscectomy during anterior cruciate ligament reconstruction. It's going to be a systematic review. We are at the article writing phase right now with the final results. We would like to have this article in the Sports Medicine Journal. Okay, about the background, you probably heard a lot about anterior cruciate ligament today, but just the basics. It connects the femur to the tibia, and it provides anterior, posterior, and rotational stability. There are around 200,000 ACL ruptures per year in the United States, from which 60 to 175,000 is reconstructed, and in Hungary, this number is around 3,500. When there is an injury of the anterior cruciate ligament, then can be several other injuries. So in 55% of the cases, there is a lateral meniscus tear, and 45% of the cases, there is a medial meniscus tear. Menisci of the knee joint are a C-shaped fibrocartilage that increase stability and distribute load inside the knee joint. There are 2 major treatment options for the torn meniscus. One is meniscectomy, which is the removal of the damaged parts, but it can lead to instability. And the other surgery is repairing it. It's basically suturing the torn meniscus, and this way we can keep the stability inside the joint. It has been shown that if we can preserve or repair the meniscus, we can prevent early onset of osteoarthritis. But still, in 94% of the cases, there is a meniscectomy performed, and only 6% of the cases there is meniscal repair. Possible reasons can be that it's quite an expensive procedure. It takes much longer, and the operator knows how to do it, needs a technique right, and also not all torn meniscus can be repaired. So our aim is to compare the safety and effectiveness of meniscus repair and meniscectomy during primary ACL reconstruction. So this was our question. We are investigating people with concomitant ACL and meniscus tears, comparing the 2 surgical interventions, and you can see our outcomes here. Our hypothesis is that meniscus repair is superior to meniscectomy during ACL reconstruction. We conducted our search in October of last year. We had more than 10,000 articles. After the selection process, we have 25 full text. Okay, our first outcome is the Lisholm score. So it's a patient-reported subjective outcome. It's assessing knee injuries. It consists of 8 items, and the score is between 0 and 100. So we compared the changes of the Lisholm score from preoperative to postoperative results. You can see the mean difference of the changes is, in case of the Lisholm score, is minus 2.6, which means, considering it's a 100-point score system, it's neither a statistically nor clinically significant difference. If we go to our different outcomes, our next outcome is the CUS outcome, CUS score system. You heard a little bit about this from Miki. It's also a score system which ranges from 100 to 0. It's also patient-reported, and it has 5 subgroups. If we look at just the results, we can see that we find 1 significant difference in the CUS pain subgroup, which favors meniscectomy, but it's only 1.6 point, so it's only a statistically significance, not a clinical significance. Okay, we managed to separate the medial meniscus injuries from the lateral meniscus injuries. So if we look at only the medial injuries, we don't see any significance here. And if we look at the lateral meniscus injuries, we also see the same thing, so there is no statistical difference. Our next outcome is the IKDC score, which is just before also patient-reported subjective outcome, and it's also score between 0 and 100. You can see all the same here. And our last outcome was the KT arthrometer. It's a device that examines the anterior translation of the tibia relative to the femur. Here you can also see there is no significant difference between the two surgeries, but the forest plot tends in favor of repair. Okay, so our strengths, that this meta-analysis is going to be more comprehensive than the others before. We could include more studies, we have much more outcomes, and we could also separate medial and lateral meniscus injuries. The limitations is that we couldn't include any RCTs, only mostly retrospective and a few prospective studies. Other limitation is that different types of meniscus tear can have different kind of surgical options. The time to surgery was heterogenic. Also, there was differences in follow-up time. It was around 1 and 2 years, and there were differences in ACL reconstruction techniques. Okay, so our conclusion is that based on our result, we did not find any significant difference in either in the efficacy of either surgical interventions. Our implication for practice is that meniscectomy can be just as effective as meniscus repair during ACL reconstruction based on these patient-reported outcomes regarding 1 or 2 years after surgery. Our implication for research is that different types of meniscal ruptures should be studied differently. Also, more RCT is needed with standardized research protocols and outcomes. There should be results at different time compared to the surgery. So we are interested in 5 and 10 years after surgery, and the studies also should be done at different age groups. Okay, our second project is also a meta-analysis. It started in November of last year. It's investigating the safety and efficacy of intra-articular injections in the treatment of knee osteoarthritis. About the background, osteoarthritis is a degenerative joint disease. It results from breakdown in the joint cartilage and underlying bone. Most common symptoms are in joint pain, swelling, and decreased range of motion. It's affecting around 30 million people in the United States alone, and majority of these osteoarthritis cases is regarding the knee joint. Okay, there are 2 major treatment options for knee osteoarthritis. One is surgical, which is mainly total knee arthroplasty. The other one is conservative. The most commonly used conservative option is intra-articular injections. This is obviously a non-operative treatment type. It presents a low risk of harm and provides short-term pain reduction and improved joint function. Several types of this kind of injection exist, for example, corticosteroids, platelet-rich plasma, hyaluronic acid, and many more. But despite having so much options, there is no clear recommendation which one to use. Also, recent studies showed great success combining hyaluronic acid with PRP. So our aim is to compare the effectiveness and safety of these intra-articular injections. This was the clinical question. We are investigating patients with knee osteoarthritis, comparing the different intra-articular options. Our outcomes are patient-reported score, also septic complications. And our hypothesis is that if we combine PRP with hyaluronic acid, it's going to be superior to the other options. Clinical implication is that if we can improve pain and function in knee osteoarthritis, we can decrease the number of total knee arthroplasties. We had several revisions to our search key, and we are planning to do the final search this month. So this is our 2 ongoing projects right now, and I would like to finish with this quote, "To infinity and beyond." Thank you for your attention.
Thank you, Gyula. I have a question to you regarding your first project. You stated that the meniscal repair percentage is around 6%,
yeah,
as far as I remember. Is it an average value, or that is typical for the other publication you examined, because it is a very low rate? You also mentioned just, is it an average value?
Yeah, it's an average value.
Mm-hmm. And what was the highest, for instance? You remember?
Well, it depends obviously on the studies, but obviously there are clinics where they are much
Maybe
more professional.
Maybe it can be around 30%? Or
yeah, there are clinics that if you look at the young population, it can reach to 30%, yeah.
Just one other remark regarding your second presentation. You know that is officially the PRP treatment is in Hungary now is banned.
Yeah, it's banned.
We cannot perform
we are
that.
not only thinking about Hungary right now.
Yeah.
Congrats, Gyula, it's fantastic work, of course, I know all the details, but anyway, I started to think about, again, this fact that actually these two interventions are indicating in quite different situations, quite different populations, and I was just thinking that in the paper, what do you think, how should we include a recommendation based on also regarding the population? I mean, for sure, I don't know, we can say that, for example, younger patients should receive a repair, and after that probably, anyway, you know, as a second surgery, the menisci can be removed or something like that. But I'm just thinking about the risk factors for the failure of any of the two interventions, and to include this in our recommendations somehow, but I don't know, what do you know about this part?
Mm-hmm. Thank you for your questions. Yeah, you are right, it's a little bit like apples to oranges, but I think in the paper we are considering writing that if we are talking about younger populations, we believe that the healing of the meniscus is more likely, so you should try to have the suture of the meniscus, but if we talk about an older generation or the older patients, maybe it's not the best idea, because obviously for a surgery like this, which is a repair, there can be a lot of complications, non-healing and others, which needs a reoperation, and but the risk and the risk ratio may be worth it at the young patients, but not at the older ones.
Just one remark to your question. The clinical picture is a little bit more complicated, because the indication for repair or meniscectomy is very different. So it depends on the type of the injury of the menisci. So it's a red zone, we call that can be repaired. And if the rupture or the injury is in a different zone of the menisci, it cannot be repaired. So that is also complicating a little bit the clinical procedure.
Yeah, if I can ask, actually, it relates to these questions, but in a very different way. That if I noticed that in your first study, I mean, when you have your plots, then the deviations were quite different in different studies. So some of them are actually the confidence intervals were quite wide, and in other ones were narrowed. And actually, this could kill the whole study, in a sense that if the population, this is not your fault. This is probably the fault of the selection of the patients. But are these studies really designed in this way that like here, I mean, or any of these? I mean, some of them are very narrow, and another one is quite wide, and then you get just about nothing or very little, I mean, outcome. So if you look at that in this sense, that did you see anything that, I mean, which is actually seems to be at least qualitatively obvious, that some of the studies are not well designed as the other ones, or the selection?
Well, it depends on the study selection, but it also depends that who made that study, because there are obviously clinics who do a lot more meniscus repair, and they are much better at it, and they obviously have better outcomes. So I think that's the main reason
because
behind
maybe
it.
This could be a way of subgrouping, actually, to add together those studies which have actually large number of operations compared to those that who just do a very little. I mean, this is an obvious, I mean, evidence, but still we don't use that in this kind of analysis, and then maybe you actually get some stronger evidence if you just go, I mean, make a cutoff and then just go for the centers which actually do lots of surgeries.